start with Dr. Krishna Kumari.
My topic would be, I would like to discuss a bit upon all different aspects of the peripartum cardiomyopathy, a clinical scenario with definition, etiopathogenesis, management and prognosis. So this was one of patients which has come to us, a primigravida, a routine antenatal patient, and with no much risk factors except that she had pallor, and she was came with labor pains, and when we did a vaginal examination, the cervix was very unfavorable. Routine investigations showed that hemoglobin was less, and the urine albumin was showing 1+, and alkaline phosphatase was a little elevated, and ultrasound showed an AFI of 3 to 4 centimeters. The patient delivered by a C-section. Prior to the delivery, the blood pressure was only 110/70 in the antenatal period. Immediate post-op period, the blood pressure moved to 140/100, and later on shifted to 150/90. So the patient was not started on any specific antihypertensives with a little bit of 1 or 2 recordings. And then on the 4th post-op day, she complained of headache followed by convulsions. Her pulse rate was 112 per minute. Her blood pressure was still normal, but the urine analysis showed that it was a 3+, albumin was 3+. So then we thought it is a case of eclampsia and went ahead with the Maxelf regime. Her uric acid, the PE profile was done. It showed 7.7 uric acid and creatinine was 1.19. Then after 24 hours, we stopped Maxelf therapy because the patient had no more convulsions. And then on the 6th post-op day, she complained of giddiness, palpitation, sweating, and SOB. Then the pallor was still there, of course. Her pulse rate was 130 per minute. The blood pressure was still normal, and there was SpO2 of 85%. So we put her on oxygen and called for the physician referral immediately. And then when the physician has done the investigations, the ECG showed just tachycardia. And then a chest X-ray was done, which showed that there was cardiomegaly with pulmonary venous congestion. Then they have ordered for a 2D echo, and all the findings of 2D echo were similar to, were pointing towards a peripartum cardiomyopathy. So what are the findings in echo that you can point out towards peripartum cardiomyopathy are dilated chambers, both the ventricle and the atria, especially the left ventricle, and mitral and tricuspid regurgitation on Doppler flow. And when you do a stress testing, there can be tachyarrhythmias. We also may not, it's not normally done, but you can do a dobutamine stress echo, which will only help you for clinical prognosis, to assess the prognosis only. This is how, in a case of the difference between a normal heart and the dilated cardiomyopathy. Dilated cardiomyopathy has many etiologies, 5% of which is because of peripartum cardiomyopathy. Here there is a heart muscle weakness and the chambers enlarge. As you can see, the septa and the wall become thinner, the volume of the left chambers has become bigger. So there are many physiological changes that happen in pregnancy we all know of, which do mimic a normal, also a heart disease. So you have a normal changes, physiological changes in a normal pregnancy, a cardiac disease, and also a condition known as peripartum cardiomyopathy, where the edges are very, very blurred. So if we do not exactly know what exactly is the, where to draw a line and define clearly which is what. And so when are you going to investigate these patients? So what needs to be evaluated promptly is when there is a new or rapid onset of any of these, like cough, orthopnea, PND, fatigue, palpitation, hemoptysis, chest pain, and patient complaints of abdominal pain. Then you need to evaluate promptly. And the severity of symptoms are once again very similar to that of the NYHS system. You have the classification is very similar to any cardiac diseases which complicates pregnancy. You can also see the symptoms and signs are also very similar, whether it is a cardiac disease or whether there is a PPCM. So the physical findings of PPCM are an increased JVP, cardiomegaly, the presence of a third heart sound, loud pulmonic components of the S2, presence of MR or TR, pulmonary rales, worsening of peripheral edema, ascites, arrhythmias, embolic phenomena, and hepatomegaly. This can all be the presenting features in case of peripartum cardiomyopathy. So, peripartum cardiomyopathy was first described in the 18th century, but was recognized as a separate clinical entity in the 1930s. And in 1971, it was Demarcus et al. Who has made 4 criteria, 3 of which are clinical and one of which is echo finding. The 3 clinical findings include a heart failure within the last month of pregnancy, or this here it is given as 6 months postpartum, but we now define it as 5 months postpartum. Absence of prior heart disease, most importantly when you have no determinable cause. And the echo findings are when there is a left ventricular ejection fraction which is less than 45%, a fractional shortening of less than 30%, or an end diastolic diameter of less than 2.7 centimeters per square meter of body surface area. Or any of these are suggestive of the presence of a peripartum cardiomyopathy. So, after that many people have come out with their own definitions and added, and the most recent is by the Heart Failure Association of the European Society of Cardiology Working Group. They sat together and in 2010 have described it as a disease of exclusion. So, now you call it as a diagnosis only by exclusion, and the left ventricle may not necessarily be dilated, but the ejection fraction should always be less than 45%. So, this is what they have come out with. The incidence is very variable. So, it depends upon, I think now that is what we were talking in the morning, the awareness has increased, or we are doing more of 2D echoes. We see so many cases of peripartum cardiomyopathy now than what we were seeing before. So, actually the highest incidence is found in Haiti. The incidence is as much as 351 in 350 to 400 live births, because they have a tradition where they eat kanwa. Kanwa means dried lake salt. They eat a handful of this salt twice daily, morning and evening, for 40 days after delivery, and this causes a lot of volume overload and probably precipitates this. So, most of these 75% of these cases are seen in the first month after delivery, of which 25% happen in the first week. So, that is about the incidence, and the causes are multiple. As you know, when you do not have a cause, there will be multiple causes. Most of the time they can be unknown, it can be nutritional, it can be immunological, secondary to viral illness or to your abnormal immune response. It can be genetic, or it can be microchimerism, where the fetal cells go into the maternal circulation and cause an immune response, or it can be an imbalance in the angiogenic factors similar to preeclampsia, the SFLTs and all. There is an imbalance between the vasoconstrictor and the vasodilator markers. And now most interestingly, now we have the newer one which is coming up is the prolactin. So, what they say is whenever there is an oxidative stress, there is more activation of the cathepsin, cardiac cathepsin D. That one splits the 23 Dalton prolactin into a 16 Dalton prolactin, and this 16 Dalton prolactin is the one which is having a lot of anti-angiogenic causes. It favors apoptosis, it causes cardiac toxicity, and this has been now been concentrated upon. If you remember this point, you will remember later on that one day you might, today still it is under study, but one day very soon there might be enough evidence to say bromocriptine will work for PPCM. So, as of now we are not going to give that outright statement, but it is been studied in quite a number of patients. The risk factors are many, but what I want to carry on from here is that there is what is called as an iatrogenic cause. Still we have some people writing prolonged periods of tocolytic therapy and some drugs. These are one of what we are causing, other than the whole list of causes which are common to all the cardiac diseases. The complications can be maternal or fetal. Fetal, it is hypoxia secondary to maternal hypoxia and decreased perfusion. Maternal, it is hypoxia, thromboembolism, progressive cardiac failure, arrhythmias, and most importantly missing the diagnosis and thinking it is preeclampsia and withholding diuretics. So, because we all know in preeclampsia we are withholding diuretics, but in PPCM we are not withholding diuretics. That is why it is so very important that you differentiate it from preeclampsia as soon as possible. So, the investigations you would like to order are to assess the kidney, the liver and the thyroid functions. You look at the electrolytes, of course, the complete blood count, and markers of cardiac injury and stress can be used, and then you have to exclude toxic etiologies. So first, most importantly, exclude preeclampsia, and then you might find an elevated CPK, which may not be diagnostic of PPCM because it can be seen in normal pregnancy, it can be seen in many other conditions. Troponin I elevations are more likely to indicate true myocardial disease. It can be because of inflammation or due to infarction. Serological testing, where you want to exclude many of these infections, and when indicated, then you also have to exclude other systemic disorders like pheochromocytoma, thyrotoxicosis, carditis, not as a routine, but only if you are not finding any other etiology. The simple would be to do an ECG, which can exclude conduction abnormalities. So results may be normal, or it may show sinus tachycardia, or rarely even atrial fibrillation when you do a ECG for this patient. And the most important thing is order for an immediate echocardiogram. Echocardiogram gives you the valve structure, the chamber size, and the valve motion too. And even in a normal pregnancy, there can be slight enlargement of the cardiac chamber. So if it's normal, now you have excluded a lung, you have excluded a cardiac issue, then you can think in terms of a lung process or non-cardiogenic pulmonary edema. If there is a diastolic dysfunction, then think in terms of preeclampsia. This is how you go about excluding. X-ray chest, yes, it's although we routinely would not like to do it, it is not a contraindication in pregnancy because the radiation exposure after shielding is very, very minimal to the fetus. So if necessary, you can order for a chest X-ray. Stress testing, you have, when you want to exclude a coronary artery spasm, yes, you have to go ahead with the stress testing, and if it is not available, you may even have to go for a nuclear imaging depending upon the necessity alone, not as a routine. Then right heart invasive hemodynamic monitoring may be needed in certain cases of class 3 and 4 heart diseases. MRI, when you have a good echo showing a low ejection fraction, there is no need for you to go ahead and do a MRI. Tissue analysis also we are not advising because the histology doesn't make you change the method of management. Immunosuppression as such has no role as of now towards the management, in the management line. The differential diagnosis is huge. So the two things I would like you all to think of is the non-cardiogenic pulmonary edema, which can be secondary to infections or your medications which you are using, or it can be preeclampsia. These two things which are more specific to pregnancy have to be thought of. So in our patient, the patient was started on oxygen inhalation, restriction of fluids. Patient and attendants were counseled and shifted to the cardiac care center. The components include oxygen and assisted ventilation as needed, optimizing hemodynamics, relief of symptoms, chronic therapies which will improve the long-term consequences, and patients with systolic dysfunction are treated as same as those who are non-pregnant. Pulse oximetry, continuous ECG, continuous fetal heart monitoring, continuous systemic arterial pressure and heart rate, and keeping the potassium more than 4 and magnesium more than 2. So the pharmacological therapy includes ACE inhibitors, the angiotensin receptor blockers, angiotensin receptor and neprilysin inhibitors. These help the heart work more efficiently, but in antenatal period we are not giving this group of drugs. Beta blockers, which cause the heart to beat more slowly, so it has recovery time. Diuretics reduce fluid retention. Digitalis strengthens the pumping ability of the heart, and anticoagulants if the ejection fraction is very low. This is your line of treatment. Digoxin and inotropics whenever there is an abnormal ejection fraction. If the patient is having hypertension, you have to start her on IV dobutamine. We had recently one case which was on IV dobutamine and then recovered, and then it also improves the placental perfusion. Then you have to if necessary, do a hemodynamic monitoring. And then diuretics, the best line, safest is the furosemide. The potassium sparing diuretics we are using only in the postpartum period as of now because the availability of the studies is very, very minimal. Beta blockers, yes, you have metoprolol, carvedilol and bisoprolol. Metoprolol is most known, but still carvedilol is a good drug. But when you are using these, you have to be careful of the fetal growth and the apnea, hypertension and bradycardia which can happen in the neonatal period too. Arrhythmia management, we have already seen ACE inhibitors, receptor blockers are avoided, and then you have the option of using hydralazine plus isosorbate dinitrate as a vasodilator. And then if it is refractory, you go ahead with starting inotropes, implantable CVDs, ICDs, and cardiac resynchronization and cardiac transplantation. This is the ultimate which has to be very rarely used. Antithrombotic therapy, yes, the chances are 50% because you know not only the dilated vessels, the physiology of pregnancy favors thrombosis, and so if there is a heart failure or the atrial fibrillation or ejection fraction is less than 30%, go as per the guidelines and do it. Antiplatelet agents, the pentoxifylline 400 milligrams is being studied and is found to be useful. Oxytocin, you have to remember that it enhances the effect of sympathomimetics and may cause hypertension and also has an antidiuretic effect. Morphine is good, immunosuppression should not be used. Bromocriptine, I have told you, it is under study and is being used, but not no evidence to say to give it as a recommendation. So other things only as and when it is it is beyond us, and it is a call of the cardiologist where they go ahead. So if the patient is presenting to you with an acute episode, give diuretics, digoxin, ACE inhibitors, beta blockades, and anticoagulation. And after that it goes into the hands of the cardiologist to go for higher. Of course, this is also with the cardiologist, it's a teamwork, and now it really moves into the hands of the cardiologist from here onwards. So once this patient has recovered, and now there is also what do you do? So what you can do is you have to continue with the treatment, and if it is left ventricular ejection fraction has improved for more than 50% and has remained like that for 6 months, then you slowly taper off the other drugs. The only drug which we use is the beta blockers. So BNP is one interesting thing which is coming up. It has a rule out. So if it is less than 100, you are more confident, but rule in saying that it is.
One more minute.
Yeah, I'll just wind up.
Thank you. Please, sir.
Yeah. So if it is BNP is less than 100, you are confident that you have ruled out, but the rule in is doesn't work, and 100 to 500 is the gray zone. Delivery is by similar to any other obstetric indications, only cesarean section unless there is a heart failure, and better to wait for a spontaneous vaginal delivery if it is permissible. Labor and delivery has to be in the HDU with all these monitors, as Dr. Leela has already said, with careful monitoring of the cardiac condition. Diet and activity, restrict salt, and the weight gain of 3 to 4 pounds per day or 2 may signal a fluid buildup. So strict bed rest, smoking, and stopping alcohol is advised. Most importantly is the follow-up. For our patient, she recovered and she was discharged with metoprolol, lanoxin, Lasix, and enalapril. And then breastfeeding, although it's not ideal, may be advised if there is no heart failure and your drugs are compatible with breastfeeding. Contraception, you know there is a chance of recurrence in next pregnancy, so sterilization or non-hormonal contraception. Prognosis, the mortality rate is 25 to 50% because of the CHF arrhythmia or thromboembolism. 6 months 50% resolved, the rest may continue and may worsen, and there are enough evidences to say that if there is in subsequent pregnancy, there might be worsening of the left ventricular function and leading to clinical deterioration and even death. So this is my last slide to tell you that all those causes which are affecting and causing a signal or activation of the cell signaling which regulates the cardiac myocyte may be a normal signal with normal pregnancy, or it may be an abnormal signal leading to peripartum cardiomyopathy. If it is happening, then most of them resolve, 50% do resolve, 50 to 60% resolve. The rest, there might be persistent left ventricular dysfunction. If there is persistence and there is a pregnancy again happening in these group of women, then there might be even death or a worsening of the LV function. So thank you.